Hi everyone, we are looking at renal physiology. In this lecture, I'm going to talk about the nephron. Okay, I'm going to talk about the nephron, which is also called the functional unit of the kidneys. Okay, so first thing first, what is the nephron? The nephron is defined as the structural and functional unit of the kidney. So each kidney consists about 1 to 1.3 millions of nephrons. However, the number of nephrons starts decreasing after about 45 to 50 years of age at the rate of 0.8% to 1% every year. Okay, so each kidney has 1 to 1.3 million nephrons. Okay, so meaning that if you have two functional kidneys, you have 1.3 times 2, which is 2.6 million nephrons. These are microscopic structures, tiny microscopic structures, okay, that you can appreciate very well with the help of the microscope. So by the time the person reaches 45, 50 years, the number of nephrons begin to reduce. Okay, so usually when the number of nephrons reduce, this is proportionally consistent with a decrease in the glomerular filtration rate. Okay, there are various factors that can lead to this: high blood pressure, diabetes mellitus, and many other kidney diseases may damage the nephron, resulting into reduction in number. Even poisons. Okay. So when the nephrons are reduced in number, it means those homeostatic mechanisms that we talked in part 1 will be affected. For example, there will be decrease in urine output. Okay, instead of regulation blood pressure, it will be difficult to regulation blood pressure. This can lead to edema in the legs, the ankles, and the feet. Okay, due to poor working condition of the nephrons, you find that the heart functions is affected, irregular heartbeats. Due to loss of nephron function, you find that even appearance of proteins in urine increases, blood in urine increase, and they'll also lead to hypoproteinemia, where there's loss of proteins in urine, thereby the levels of protein in the blood drastically reduces. So in short, what we're trying to say is that when the levels of when the number of nephrons reduce, even the functions of the kidneys reduce. Okay. A typical nephron has this structure. Okay. This is a structure of the nephron. We looked at blood flow into the kidneys. So we'll pick it from renal artery. The renal artery, they move or they change into the afferent arterioles. And then the afferent arterioles, they form capillaries within the Bowman's capsule. So that capillaries are called glomerulus or glomerular capillaries. Okay, that's where that's where there's exchange of materials. In other words, there's filtration taking place there in the glomerulus. From the glomerulus, it comes out through the efferent arterioles, and then through this what we call the vasa recta and the peritubular capillaries. So this is a structure of the nephron. We have those nephrons that are located in the cortex. We call them cortical nephrons. And those nephrons that are located in the medulla, in the medullary region, we call them the juxtamedullary nephrons. Okay. So this is a typical structure of the nephron. So it's just important as the first from the, this is called the renal corpuscle. Okay. So the nephron has two parts: the renal corpuscle and the rest of the tubules, the renal tubules. So these, they make up the nephron, the renal corpuscle, and the renal corpuscle comprises of the Bowman's capsule and the glomerulus. And then the other part of the nephron is the renal tubules. Okay, so that's the structure of the nephron. Now there is this important table which shows some of the differences between the cortical nephrons and the juxtaglomerular nephrons. Okay, so in terms of location, the cortical nephrons are located in the cortex. The juxtaglomerular nephrons are located in the inner part, the inner part of the cortex, next to the medulla. Okay, and in terms of the glomerulus, we know glomerulus, these are capillaries. The cortical nephrons, they are smaller, but the juxtamedullary nephrons, they are big. In terms of the loop of Henle, for the cortical nephrons, it's shorter. For the juxtaglomerular, it's longer and into the inner part of the cortex. Okay. In terms of diameter, that is AA, that is afferent glomerular arterioles, and EE, it's efferent arterioles. In terms of diameter, the afferent arterioles have a bigger diameter as compared to the efferent arterioles. Okay. But here, in terms of diameter of the juxtaglomerular, the afferent arterioles are equal to the efferent arterioles. Okay. So the diameter of efferent arterioles is about 2. It's just the ratio between the diameter of the efferent arterioles and the afferent arterioles, and this one is 1. The other difference is the efferent arterioles, where do they go? They form the peritubular capillaries. Okay. But for the efferent arterioles of the juxtaglomerular nephrons, where do they go? They form vasa recta. These vasa recta, you are going to see that they are parallel to the loops of Henle. Okay, they are parallel to the ascending and the descending loops of Henle. They are very important in countercurrent mechanisms, which we are going to see later on. In terms of innervation, the cortical nephrons, they are rich, innervated by the sympathetic nerves, but the juxtamedullary nephrons are poorly innervated. Concentration of renin, it is high. The renin-producing cell, they are high in the cortical nephrons. There is almost none in the juxtamedullary nephrons. In terms of ratio, we have a lot of cortical nephrons, and we have few juxtaglomerular nephrons. Okay, in terms of functions of the cortical nephrons, they are involved in reabsorption and secretion. But the juxtamedullary nephrons, they are involved in concentration and dilute urine production. Okay, so these are some of the differences between the cortical nephrons and the juxtaglomerular nephrons. But at the end of the day, they are all nephrons. And their function is to reabsorb, to secrete, and to concentrate urine. Okay, so it's just important to understand these differences. Okay, it's just important to understand these differences. So these are the nephrons which are located in the cortex. It's like these are the most abundant, and these are the nephrons located in the boundary between the medulla and the cortex. That's why we are calling them the juxtamedullary nephrons. So the renal corpuscle, it's located juxta, side by side to these boundaries. Okay. So at the end of the day, they are all involved in functions of the kidneys, that is reabsorption, secretion, concentration, and dilute urine production. Okay. So these are the functions of the nephrons: filtration, tubular reabsorption, tubular secretion. Now, what's the difference? Filtration is just separation. It's a separation technique. If you remember in your chemistry, there are what we call separation techniques: filtration, simple distillation. Which other separation techniques do you remember? Fractional distillation, evaporation. All those are separation techniques. So there's also a separation technique in the kidney called the filtration. So you are removing the small particles. There are those particles that can pass through the filter. They form what we call a filtrate. Okay, and those that remain on the filter paper, they are what we call the residue. So in the case of the kidneys, the residues, they remain in the glomerulus, in the glomerular capillaries. In other words, they remain in the blood. These are bigger molecules such as, or bigger compounds such as albumin, these plasma proteins, red blood cells. Okay, those that cannot penetrate through the fenestrated capillaries. But the filtrate, it comprises many substances: the electrolytes, mention of sodium, potassium, chlorides, water, even glucose and amino acids. They are filtered. Okay, and then they move into the renal tubules. That's the meaning of filtration. It's a separation techniques where a pressure will cause this process. That pressure is called the hydrostatic pressure. So liquids are moving from the region where they're in high hydrostatic pressure to a region where there's low hydrostatic pressure. And then we have tubular reabsorption. Tubular reabsorption is just the opposite, or the direction. It's in the opposite direction to filtration. Substances that are very important for the body, they should go back, okay, into the body. For example, glucose. 100% of glucose in a normal healthy person should be reabsorbed. Even amino acid, they should be reabsorbed. Okay. So reabsorption is dependent upon the concentration of that substance in blood. Okay. Reabsorption will be dependent upon the concentration of the substance in blood. For example, if you have too much sodium, do you expect a lot of sodium to be reabsorbed? No, you don't expect that. For example, if you have a lot of acids, like in acidosis, do you expect the hydrogen ions to be reabsorbed? No, you don't expect. So reabsorption will be dependent upon the concentration of a particular solute in blood. Like, for example, in a person with diabetes mellitus, these people usually have high blood sugar levels. So you don't expect 100% of glucose to be reabsorbed. Some of it will appear in urine, which we call glucosuria. Okay, which we call glucosuria, the appearance of glucose in urine. We'll talk about that. So there should be a tubuloglomerular balance. Okay, and then there's also tubular secretion. There are some substances that were not filtered. Okay, also there are some substances which were filtered, but they still remained in the blood. Okay, so those substances will be secreted. Okay, so secretion is just substances which were not filtered, but can still be secreted from blood into the renal tubules. Okay. Now secretion, the components of the kidneys that are involved in secretion, these are the vasorectors. Okay. Those are capillaries that run parallel to the loops of Henle. We saw them somewhere like this. So secretion of the substances will occur. We'll look at specific examples. Now there's, we said that the nephron has two components. There's a renal corpuscle, which is made up of the renal corpuscle is made up of the glomerulus and the Bowman's capsule. Okay. And then the other component is the renal tubules. So we'll just briefly try to understand this renal corpuscle. What is it? Very important, because the renal corpuscle, that's where we can see this filtration taking place. Or that's where we can see glomerular filtration rate. Okay. So we have an afferent arterioles bringing blood to the renal corpuscle. And then the afferent arterioles divides into these capillaries. These are called glomerulus. Okay. And then there's another efferent arterioles that drains blood in the glomerulus. Okay. So the filtrate from the glomerulus will move into this space here. These spaces. We can call them the capsular space. Okay. The capsular space, or the space in the Bowman's space. Okay, so the filtrate will move into that. What is actually being filtered is plasma. Okay, and we know that plasma is 55% of blood. Okay, so it's what is being filtered. So it will move into the capsular space. Now from the capsular space, there will still be buildup of pressure. So we want the fluid to move into these tubules. So it will pass through certain layers. Okay. It will pass through the certain layers. Okay, one of the layers which it will pass through, I've shown them in here. Okay. So the filtrate, first of all, it is here. No. Yes, that's where the filtrate is. This is what we call the glomerulus. Now the capillary itself, we know the capillaries, they have endothelium. So in between there is a pore. Those are called fenestra. So it will pass through the fenestra, or the fenestrated capillaries. Okay. And it has to pass through the basement membrane. Okay, which is made up of collagen type 4 materials and many other substances. Okay. Once it passes through that, the filtrate also has to pass through in between the pedicels. They are what you call the slit pores. Okay. So this is the direction of the filtrate. Let me just repeat. The filtrate is, the blood is coming from the afferent arterioles. It accumulates in the capsular space. So for it to be filtered, it has to pass through the fenestra, from the fenestra through the basement membrane, the basement membrane through the slit pores of the pedicels. Okay, so this is our filtration barrier. Very important filtration barrier, so that when you look at pathological conditions, you're going to see that there are some conditions like glomerulonephritis, inflammation of these same barriers. It means it makes even the membrane so permeable. Okay, it increases the permeability of these filtration barriers. So in a normal healthy person, filtrate should pass through the fenestra, through the basement membrane, through the pedicle. Okay, in case you are confused, what is a pedicle? A pedicle, these are just finger-like projections. Okay, so a podocyte has pedicles. So a podocyte has pedicles. A podocyte has finger-like projections. Okay, so this is the same diagram trying to explain the renal corpuscle. Okay, cross-section of view, this is what you can see. Okay, at cross-section of view. Okay, so the capillaries, the glomerular capillaries are there. The capsular space is somewhere there. Okay, and then there's a parietal layer of the glomerular capsule somewhere there. Okay, so this is how a podocyte looks like. A podocyte is like they wrap around the glomerulus. So they form one of the filtration barriers in the renal corpuscle. Okay, so this you can appreciate at your own time. Just try to understand these labels. Okay, these are the same things we are talking about. And then D, it's showing in a real person, the arrangement using electron microscope. This is what you can see. Okay, so just to summarize about the filtration barriers, from a cross-section of view, we can have something like this. Okay, we know the leukocytes, they remain in the blood. These are residues. The platelets, they will remain in the blood. Large proteins like plasma proteins will remain. The erythrocyte will remain. So what is being filtered are dissolved substances in plasma. Okay, so they will pass through the fenestrated capillary endothelium. They will pass through the glomerular basement membrane, and then they'll pass through the filtration slit diaphragms between the pedicel or the pedicles. Okay, so filtrate includes water. The filtrate will include amino acids, ions, urea, many hormones, vitamins B, C, ketones, and a very small amount of protein. Okay, so this is the renal corpuscle. Now let's look at the portions of the renal tubules. We say the nephron has two compartments, the renal corpuscle and the renal tubules. Okay, renal corpuscle and the renal tubules. So from the renal corpuscle, the first part of the nephron is called the proximal convoluted tubules. That's the first part of the nephron. Okay, and then at the end of the proximal tubules, it becomes thick, so we call that the thick descending segment. Okay, and then from the thick descending segment, it forms a loop of Henle. But this one is called the thin descending segments of the loop of Henle. Okay, and it makes a hairpin bend. Hairpin. You know what a hairpin is? Okay, it makes a hairpin bend. And then this that ascends is called the thin ascending segment of the loop of Henle. Okay, which is this one here. And then from the thin ascending loop of Henle, it becomes thick. Becomes the thick ascending segment of the loop of Henle. And then from the thick ascending, it becomes a distal convoluted tubule. This is convoluted tubule because it is coiled. Okay, and that's where we're going to see the macular densers. Okay, those are cells that are sensitive to the levels of sodium and chloride in the renal tubules. So from the distal convoluted tubules, we now the the filtrate will move into the collecting duct, and then finally there'll be urine, which will move into the minor, the major calyces, the pelvic region. Okay, and urine will go all the way to the bladder via the ureter. From the bladder, urine will be expelled via the urethra. Okay, so this is the tubular portion of the nephron. We just need to know the segments, because various segments, they play various functions. Okay, various segments, they play various functions. And then from pharmacology, you are going to see that various agents called the diuretics, they have mechanism of action on various segments. Okay, so this is the parts of the nephron. It has the proximal convoluted, the thick ascending segment, the thin ascending segment, the thin ascending segment, the distal convoluted tubules, and finally the collecting duct. Now there's this, my favorite table here. This one you have to pay very particular attention. Okay, the title is Major Functions of the Nephron of the Segments. Major function of nephron segments. Okay. In a normal healthy person, okay, these should be the functions of the various segments of the nephron. In a normal healthy person, these should be the functions of the various segments of the nephron. So at least for every segment which we discussed previously, you need to know the major function. Okay, you need to know the cellular mechanism that ensures that the function is performed. So you need to also know various hormones that act on that particular segment, because there are certain segments that have receptors for particular hormones. Other segments do not have receptors for particular hormones. Okay. And lastly, I've included diuretic actions. Okay. Diuretic actions, these are drugs, usually synthetic drugs, that are used to trigger excessive production of urine, dilute urine. Mostly these drugs are used in management of high blood pressure or extracellular volume expansion. Okay, so the first part is the early proximal convoluted tubules. What is the major function? The major function is what we call isosmotic reabsorption of solutes and water. So most of the solutes that were filtered, they are reabsorbed. They go back into the blood. That is called isosmotic reabsorption. Okay? Meaning that the concentration of the filtrate, or in other words, isosmotic reabsorption, meaning there's no change in the concentration. The same concentration of the filtrate is the same concentration of filtrate that has been reabsorbed. So equimolar amount of solutes that were filtered are reabsorbed. That's a major function of the proximal tubules. So most of the reabsorption takes place in the proximal tubules. The glucose, amino acids, they are reabsorbed. The phosphates, the sodium, they are reabsorbed. So what are the mechanisms? In terms of mechanism, you have to talk about the transport mechanism. If you remember, we discussed transport mechanism some time back. We said that cellular transport mechanism can either be passive or active. Okay, and passive we said is just diffusion, and active we said it uses energy. It can either be secondary active transport or primary active transport. So there's nothing strange about the cellular mechanism. You just have to be able to identify the transport mechanism involved. So in the early proximal tubules, there is secondary active transports. We have the sodium glucose transporters, the sodium amino acid transporters, the sodium phosphate cotransporters, and we have this one, the sodium hydrogen exchanger, okay, as a transport mechanism. So in other words, if somebody asked you, in the proximal tubules, how is sodium or glucose reabsorbed? Glucose is reabsorbed via the sodium glucose transporter, which is a secondary active transport. And this secondary active transport is also dependent on the primary active transport if you connect. And just on the same early proximal tubules, what hormones act on these proximal tubules? We have PTH, which is parathyroid hormone. It inhibits sodium phosphate cotransporter. And we also have angiotensin 2. It stimulates sodium hydrogen exchange. Okay, if you remember parathyroid hormone, this hormone is secreted by the parathyroid gland. The function of the parathyroid gland is to increase the levels of what? The levels of calcium in the body. Okay. And usually it is released when there is a change in calcium levels and also changes in phosphate levels. That's why when PTH is secreted, it will inhibit sodium and phosphate cotransporters. Okay, it will inhibit sodium and phosphate cotransporters. Angiotensin 2 stimulates sodium hydrogen exchange. Okay, we'll still come back to this, especially when we look at regulation of electrolytes and blood pressure by the kidneys. And then in terms of diuretic action, the osmotic diuretics, they act on this segment. The carbonic anhydrase inhibitors, they act on this segment. Okay. As if that is not enough, there's another segment called the late proximal tubule. There's also isosmotic reabsorption of solute. By what mechanism? By the sodium chloride reabsorption, driven by a gradient of chloride, the chloride gradient. Hormone action, there is nothing here we can talk concerning hormones. Diuretics, which diuretics mode of action? The osmotic diuretics, they act on the late proximal tubules. And then on the thick ascending limb of the loop of Henle, what's the major function? The thick ascending limb. Okay. Remember the thick ascending limb of the loop of Henle. You should always remember this. It is impermeable to water. Water cannot be reabsorbed in this segment. That's why this segment is called the diluting segment. If water cannot be reabsorbed, it means the filtrate in that segment will have a lot of water. Okay? It's called the diluting segment. But there are substances that can be reabsorbed. We have the sodium chloride without water. That's their function. They reabsorbed sodium chloride without water. Another function which I've already mentioned, the function is dilution of tubular fluid. Okay, and single effect of countercurrent multiplication. There's also reabsorption of calcium, magnesium, driven by lumen positive potential. Okay, so that's a function of the thick ascending limb of Henle. And what cellular mechanism is the sodium potassium 2-chloride cotransporters? There's a pump which is able to reabsorb in the same direction sodium, potassium, and 2 chlorides. So hormone action, this pump is stimulated by ADH. It stimulates the sodium potassium 2 chloride. And the mechanism of action of diuretics, the loop diuretics. Okay, so if you hear of the word the loop diuretics, their action is to inhibit the operation of the sodium potassium chloride cotransporters. Okay, and then as if that is not enough, there's also the early distal tubules. The early distal tubules, before the tubules becomes late distal tubules, there's an early portion. Okay, that early portion, it's involved in reabsorption of sodium chloride without water. It also called the dilution of dilution segment. What mechanism? There is sodium chloride cotransporters. What hormone can stimulate these cotransporters? We have PTH, stimulate calcium reabsorption. Okay, in that same region. And which diuretics? The thiazide diuretics. So the mechanism of action of the thiazide diuretics is to inhibit the sodium chloride cotransporter. And remember, the mechanism of action of the loop diuretics is to inhibit the sodium potassium 2-chloride cotransporter. And then we have the late distal tubules. The late distal tubules. The late distal tubules and collecting ducts, what's their function? They reabsorb sodium chloride. There is potassium secretion also. There is variable water reabsorption. There is variable water reabsorption. What do we mean by variable water reabsorption? It depends on the water status. These are segments which are under the influence of ADH. Okay. What cellular mechanism do they utilize? There is sodium channels which is called the ENEC. This is the same sodium channel which is found in the intestines. They also have potassium channels. Okay. Which hormones act in this segment? There is aldosterone, which is secreted by the adrenal gland, which stimulates sodium reabsorption. Okay. And at the same time, it stimulates potassium secretion. Which diuretics act in this segment? We have the potassium sparing diuretics. Okay. And apart from that, I've forgotten one thing. The cellular mechanism also, it employs the aquaporin 2 water channels. So we are going to look at that during production of dilute urine and concentrated urine, this segment is very much involved. And then the last segment, we have the late distal tubules and collecting ducts, specifically the alpha intercalated cells. Here we are talking about the principal cells. Now the alpha intercalated cells, these are specifically associated with hydrogen ions. So there is reabsorption of potassium and then the secretion of hydrogen ions. By what mechanism? These, they employ what we call primary active transport mechanism. Okay. Most of these things, the cellular mechanism we've discussed, these are secondary active transport. But the transporters at the late distal tubules and collecting duct, they operate directly utilizing energy. That's why they are called primary active transporters. And then the hormone action, we have aldosterone, which stimulates hydrogen secretion. Okay. Remember, aldosterone stimulates hydrogen secretion, at the same time increasing sodium reabsorption. Which diuretic acts here? We have the potassium sparing diuretics. Okay. So these are the functions of the various segments of the nephron. Okay, so in short, what I'm trying to say is that you need to understand at least the major function of the various segments of the nephron. You need to understand cellular mechanisms that are employed to perform that functions, and then the hormone actions, okay, the various hormones that can act on those segments, and then the diuretic action. Okay. But for the sake of this lecture, we are going to look at how the kidney handles certain substances like glucose, how it handles sodium and chlorides, how it handles potassium, how it handles calcium and phosphates, and how it handles water. Okay, we won't look at many other electrolytes. We'll look at these electrolytes of physiological importance, like we know sodium chlorides. They affect the osmolarity of blood. The glucose, very important compound for energy production. So we'll look at these solutes, how they are handled by the kidneys. Okay. The other important thing, also you need to appreciate the histology of the various segments of the kidneys. Okay. You're going to see that they differ in the way the cells are. These are, of course, they are epithelial cells. But like those in the proximal tubules, because they do much of the reabsorption, you find that they have brush borders. Okay, those finger-like projection. So that is just to increase the surface area of reabsorption. So they differ in histologically. Okay, look at the structure of the thin ascending limb of Henle. Okay, they have a few brush borders. Same applies to the thick ascending limb of Henle. We have also the distal convoluted tubules there, the intercalated cells, which are involved in hydrogen secretions, okay, and the principal cells, which are involved in sodium reabsorption, potassium secretion, and then we have the collecting duct. Okay, so here I won't waste much time, but it's just important to know that histologically the various segments of the nephrons, they differ. Okay. So in summary, I can summarize to say that nephrons, they are the basic unit of the kidneys. In each kidney, it has 1.3 million nephrons. The parts of the nephron includes the renal corpuscle and the renal tubules. And then under the renal corpuscle, there are important filtration barriers, the endothelium, the basement membrane, and the podocytes. Okay. Under the renal tubules, it's important to know that there are various segments of the tubules and they perform various functions. And there are some transport mechanisms that can either be diffusion, that can either be secondary active transport, and primary active transport. Okay, so this is where we end. Thank you very much.